Hello, good afternoon. I'm Adrian James. I'm the Registrar of the College and the President-elect. Welcome to the third of our webinars on the subject of COVID-19. And the theme for this afternoon is legal changes associated with COVID and caring for healthcare staff, both very important issues that I know you'll be keen to know about. We've got over 1,000 people who have registered for this webinar, which is good to see. There's an opportunity to ask questions of our speakers. They'll answer those at the end of the three presentations. We would like questions related to the topics that we're talking about today. We know that there are lots of other issues in relation to COVID and the operation of the college that you may want to ask. And in the Q&A box on the right of your screen, Isabel has published a link where you can actually post more general questions, and you can also access that on the college website where it has information for members around COVID. There's a drop-down box for questions that you want to ask. So before I introduce our speakers, I just wanted to say three things. First, a very big thank you to all of you who have done a sterling effort to keep services running and provide care and treatment for our patients. People have been working at home just as hard as working actually on the clinical front line, and it's been amazing to see the innovation. I did my first mental health tribunal remotely this morning, and actually went very well. So thank you for all that you've done. I guess the second thing is that COVID will have affected all of us in some way, absolutely all of us, but many of us will have had very different and personal experiences. There have been changes to our working patterns, there have been changes to our everyday lives. Some of you will have actually experienced COVID yourself or know somebody who's been infected with COVID. And sadly, there have even been some deaths of people working in services. So it's very important that we look out for each other, we link with people, that we buddy up, that we ask people how they are at the beginning of the day, the end of the day, and not forgetting those that are remote working, and that can be really very isolating. So important that we look after ourselves so that we can look after others. And third, although these have been very challenging times, it's also been amazing to see the amount of innovation and people working in different ways. And it'll be important for us as a college to look at the best of what's actually happened and learn some really positive lessons. But of course, there'll be many things where people have not got the service that we would have liked them to have experienced, and also that many of you, your working practices have been a really very big challenge. So we'll need to do a piece of work as a college and as mental health services in order to get the best out of what has been a very challenging time. So now I'm going to introduce our first speaker, and our first speaker is Dr Clementine Maddock. She's the Medical Director at Priory T. Catherine in Cardiff, and she's the college's Special Advisor on mental health law. She's both a psychiatrist and a barrister, so I think she's well placed to talk to us about the changes in mental health law in relation to COVID. So I'm now going to pass over to Dr. Clem Maddock.
Thank you very much, Adrian. And hopefully the slides are coming up. I can't quite see them yet, but maybe there's a delay getting to Wales. So I will just speak through them, and I apologise that the slides aren't up yet, but can anyone see can you see the slides? Not yet.
Yeah, the slides are showing.
Okay, right. So there is clearly a delay over the Severn Bridge. The Teams people haven't paid their tolls, so I will talk through slightly blind. So the first slide is just the heading, and if we go to the next slide, please. This slide has the Coronavirus Act 2020, and the relevant section of the Coronavirus Act is Section 10, which are the temporary modifications of mental health in England and Wales, and mental capacity legislation in Northern Ireland, and the Social Care Act in Scotland. So this will be an England and Wales focused talk, because I'm afraid I'm not familiar with the legislation in Scotland and Northern Ireland. So Section 10 allowed for a number of emergency powers and changes to the Mental Health Act. So these emergency powers are not yet in force, but the whole purpose, and if we can go on to the third slide, please, general guidance. So the whole purpose of the powers is that it prevents any delays in treatment of our vulnerable patients. For example, if there are not enough doctors available to complete sections. So to prevent any unnecessary delays in care. The emergency powers are not yet in force, and if they should become law, then they should only be used where there is a strong justification for doing so. So where the use of the usual Mental Health Act procedure is impractical or would involve undesirable delay. And new forms will be produced if these changes happen, which will allow space to document reasons justifying the use of the emergency legislation. If we go to the next slide, please, that's sections 2, 3, 5, 4 and 5, 2. So changes to sections 2 and 3. So again, where it's considered impractical or would involve unnecessary delay, 1 instead of 2 registered medical practitioners plus an AMP can complete a Section 2 or a Section 3 form. A Section 5-4 completed by nursing staff will increase from 12 hours to 6 hours to 12 hours, and a Section 5-2 will increase it in time length from 72 hours to 120 hours. The other interesting feature of the Section 5-2 is that instead of it being completed by the clinician in charge of a patient's treatment, it will now be completed by any registered medical practitioner or approved clinician. Thank you. Could we have the next slide, please? There are, just to say about the changes to sections 2, 3, 5, 4 and 5-2, they potentially apply to England and Wales, but there will be a different procedure. So potentially the changes to the civil parts of the section could be enforced in England, but not in Wales. So the Welsh Government would need to give their consent for changes to the civil parts of the Mental Health Act to take place in Wales. Part 3 is the criminal justice measures, and these will apply in England and Wales. The Ministry of Justice powers are not devolved to the Welsh Assembly. So the main changes here, that sections 35 and 36, which are periods of remand to hospital for either reports or treatment, will no longer be capped at 12 weeks in total. And if we could go to the next slide, please. So sections 36, 37, 38, 45A and 51, there will only need to be the evidence of 1 medical practitioner rather than 2, but that medical practitioner must still give their evidence orally in court. The other change to these criminal justice sections is that the Secretary of State can transfer a prisoner to hospital on the basis of 1 medical practitioner report, not 2, and the hospital has 28 days rather than 14 to receive the patient. As I said, none of these changes are yet in force. Changes to section 135, next slide please. Section 135 and 136, a person can be held at a place of safety for up to 36 hours instead of 24 hours. Next slide please. So the next slide, it talks about section 58, administration of medicine for more than 3 months. Currently, a SOAD needs to provide a certificate of section for treatment after 3 months, But the proposals are that a treating AC or responsible clinician can provide the certificate that the medication is appropriate instead of the SOAD, so effectively doing away with the SOAD safeguard. And the treating clinician or SOAD consults with one other person who is involved in the patient's treatment instead of two. So, but they should not be a nurse, doctor, or the RC. The feedback from SOAD service, both within the CQC and HIW, is that generally changes to the SOAD system, which I will talk about on one of my final slides, have been successful in keeping the service going, but those of you listening may have different experiences. So I think that it may be possible that this, even if other parts of the Coronavirus Act are enforced with respect to the Mental Health Act, I think this may not be one of them, because the SOAD safeguard is considered, quite a significant safeguard, and there are alternative ways of working which will ensure that process can still take place. Next slide, please. So the next slide talks about tribunal changes. So the tribunal changes are currently in force. There's a slightly different way that they were enacted within England and Wales, but the outcome is effectively the same. So pre-hearing examinations have been suspended. Obviously we've all cancelled visits and people visiting the hospital. The second major change is that it can be a judge or legal member only, unless the judge decides otherwise. I've just finished the telephone tribunal, and actually it was a 3-person panel, and this was a fairly non-contentious case. So I suspect that where the appropriate number of people can be brought together, that will still happen, but obviously in extreme circumstances that may not. There can be tribunal on the papers in certain cases, so for example for CTOs, or if it's not contested. And I think many of us will have already experienced telephone or video hearings are now taking place. I understand in England that they found the telephone hearings have taken too long, and they are proposing that video hearings take place. Although, as somebody speaking from a telephone, because my video conferencing doesn't work, I'm not sure if hospitals' capability will be able to keep up with that. So, final slide on second opinion appointed doctors. Again, there's a slightly different process between England and Wales. It's CQC who regulates SOAD in England and HIW in Wales, but the changes are the same in that SOADs will no longer visit. They will consult with the patient and professionals by either a telephone or video call, and that they are requesting a summary of the care records to be sent with the request for a SOAD. So, for example, an admission report, recent care plan approach or care and treatment planning meetings, or a recent tribunal or manager's report. And SOADs have also been advised to only produce electronic copies of certificates rather than postal copies with a wet signature. So, thank you very much for your time, and back to Adrian.
Well, thanks, Clem. That was very clear and very thorough. We've already got some questions on the right of the panel, so I'm sure you'll be considering some of those whilst the other speakers are presenting. Just to remind you that you can also tweet about the live webinar, hashtag RCPsych, live at RCPsych. So I'd like to now move on to our next speaker, Professor Richard Williams. Richard was a child and adolescent psychiatrist for 38 years and is Emeritus Professor of Mental Health Strategy in the University of South Wales. Since 2005, he's researched and written policy relating to the psychosocial and mental health aspects of disasters. We're so pleased that he's our lead advisor on disaster management at the Royal College. He's advised the Department of Health for England and even NATO on guidance in relation to this topic. And he's also currently researching the impacts of the Manchester Arena bombing in 2017. So I'm now going to pass over to Professor Williams to talk about caring for healthcare staff.
Well, good afternoon. Could I have the first slide, please? I'm not sure if I'm going to see it in the right time sequence because there seems to be a lag here. But let me start anyway. So I want to think ahead a bit. I want to talk particularly about the whole business of how do we get out of the circumstances that we're in right now. I want to first start with some positive observations. I want to talk about how do we recover from the circumstances we're in, and how are we going to support staff now, and what would we like the NHS to be like when we've done. So let's go to the next slide. It's been a real privilege to work with so many people on the front line. It's amazing what you can do these days from your office at home. But what I've observed is there's huge camaraderie and enormous altruism among staff. But that shouldn't obscure from our view what are some substantial challenges. I'm reminded of what Richie Calder said when he was appointed to review what was happening in East London during the Blitz in the Second World War. And here's a sentinel statement, that the thing that sustains people is not letting the other fellow down and forgetting self in the common danger. Now, I think I've seen that in wholesale terms from frontline staff. So those are some of the positive things. But the question in my head is, how long will that go on before the thing becomes less positive? And how would we benefit from that in the future if we were able to have charge over what the NHS was like when we've done? So let's go to the next slide. Now, back in my inaugural address as a professor, I was talking substantially about this thing called moral architecture. I came to a view that an organisation, or the staff in the organisation, were only as good as the organisation was. And so for me, moral architecture refers to the moral and human rights, obligations and responsibilities for staff that organisations acquire by virtue of them employing those staff. And this is a quote from the paper that I wrote about that, about what it means to be moral. I've so far come across only one example in a mental health trust where the trust put up the things that they would do for the staff if the staff did the following things for their patients, and they were mirrored across each other. It was quite an impactful poster. So I think the thing that lies behind what I'm saying today is that we need our NHS organisations to be moral. Can we go to the next slide? And the important thing about being moral is that the NHS needs to deal effectively with the recovery stage. Let me pick something from further down this list. The staff that I mix with in intensive care units are really quite worried about how things appear later. What is the NHS going to be like when the restrictions and the number of cases drops? And how do we avoid the collision of the recovery phase with the NHS's wish, I've no doubt, to pick up deferred elective care? And will the recovery phase in any way collide with winter pressures? What lies behind this is a view from certain staff, perhaps cynical, perhaps realistic, that is there a risk that they will be asked to go from a period of very intense activity, altruistic and huge risk-taking, albeit in a calculated way, into the next phase of demand. I think the realistic thing is we've got to face the fact that the staff will need rest and recuperation. They will need time to recover, and this isn't going to come easy, and it could well be that the recovery time will be extended. There's quite a lot of research from much more contained disasters to suggest that's the case. The impact on the rescue staff after 9/11 showed that the impacts on the staff didn't actually peak until several years later. The other thing that the people in the front line are very concerned about is that staff should be credited with what goes right, and they should be enabled to own the successes of the system, and they ought to take the opportunities to carry the positive lessons forward. That having been said, there are a number of particular groups of people about whom I feel some concern. I've been written to yet again today by the chair of the General Medical Council. But I'm concerned about how we treat and look after people who return to practice. Some people are doing this enormously altruistically and taking on quite a lot of risks. But just sending them a letter saying thank you at the end will not do, in my view. We need to think about training. We've got a number of new entrants, nurses and doctors who are qualified before their time, and they probably missed out, arguably, on some quite important periods of time in their final aspects of their training. How is that going to be made good? How are we going to meet the needs of trainees? Especially those trainees who've been moved elsewhere during the crisis. Now, I've just been part of a committee where we were discussing that. I don't think we know of a lot of psychiatric trainees who've been moved, but I'm talking about across the board, about the whole of the healthcare service, and I think there are substantial numbers of trainees who've been asked to step up. So how do we restore their disrupted training? How are we going to restore the organisations themselves? And let's remember that we don't come from a level playing field, that before the COVID pandemic, the entente was not too cordial inside the NHS. A lot of staff have been talking to me about the issues they've faced, the problems that they work in, and their feelings of demoralisation. I think those things might come back to bite us later if we're not careful, but that might also more positively be an opportunity to pick up on some of those and actually deal with them during the recovery phase. So let's go on to the next slide. Here I want to talk about what I call primary and secondary stressors. The primary stressors are things that are inherent in particular events and circumstances that arise directly from those events. So we're talking about the worry that staff have about becoming infected, the worry that they have about their families at home is perhaps secondary to that, but not very far away. But these are essentially stressors that are generated by attending to the needs of patients and the consequential work and judgments required of staff. Again, Claire Marks's letter from the GMC to me today, and it's a round robin, so it'll have gone to a lot of people, implies that the GMC wants staff to make judgments, and that, of course, is another stressor. What do the people on the front line say about this? Well, they say that they actually went into the jobs that they do knowing that they would face the risks that stem from primary stressors. I've got to know a lot of people who work in pre-hospital emergency medicine and in emergency medicine departments. And because I'm doing a project at the moment for the Royal College of Surgeons of Edinburgh, they're particularly concerned about trainees in that regard. What is clear, though, from the look that we've been doing for the last year, is that this is not necessarily the most stressful aspect of the work they do. We come back to the secondary stressors. But before we get there, let's just go on to the next slide. There is evidence-based information to suggest that responders experience greater effects when children are involved, when colleagues are involved, and I think we've seen some of that. Older people are involved and disabled people are involved. And the responders' reactions tend to be worse if people have died. I won't read on through the whole list, but it's very clear to me that our responders, the people in the front line, will have been through all of this. And that, of course, includes psychiatrists as well, whose lives will have been changed very substantially by what they've witnessed. So let's go on to the next slide. And I want to look particularly at this aspect of things. Now, I won't go in any depth about moral risk, moral frustration, moral distress, and moral injury, because I'm no doubt that Simon might want to talk about some of those things. So that's on that next slide. Just say I think this is quite a good diagram that comes out of an article published last year, which shows the kind of, in a rough diagrammatic way, the relationship of these things. And this is a topic which is receiving particular attention right now, and in which, when I talk about this with people in acute healthcare circles, they take to this concept very readily. So the next thing is to go on into the secondary stressors. So if you think those things are bad enough of coping with the risk, coping with the absence of sufficient PPE, of coping with the moral risks and the judgments that people have to make, then that actually is not the most stressful part of the work. Let's look at this slide on secondary stressors next. Here we've got, these are stressors that don't come directly from the events that are being dealt with, but concern the circumstances in which staff are practicing. And down here is a quote at the bottom of that from a chapter written by Neil Greenberg and myself, that leaders should be cautious about ascribing the stress that staff experience as necessarily resulting from what they have witnessed and the work they have done or not done. So here we're talking about a whole realm of impacts, which I think are sometimes a bit slow to look at. But what I have heard is that some of these secondary stressors have come up in the 74,000 contacts that have been made in just a week with the helplines that are available to staff through the work of the NHS staff task force. So let's go on and look at what some of those might be in the next picture. So here we have a slide which contains a list of primary stressors, and these were written for me by people who do this work, and the secondary stressors that they face. So you will see in green on the left-hand side, there are some things which I think you will all too readily understand and experience. And on the right-hand side are a list of these categories of secondary stressors. Now, I might add that although I've stressed some of the positives, that there are indicators from the conversations I've been having with people on the front line and from some of those returns from the helplines that in fact a goodly number of those items on the right-hand side are brought up by staff. The lack of PPE is the number one. Concerns about own family is probably number two. And some of these other matters are coming up recurrently. And we intend to do a bit of work to look at how frequent those are. But the point I'm making is that we've really got to get to grips with those things if we are to reduce the strain on staff into the future. Because these are constants, they arise whether or not there is a pandemic. I think they've just been pushed into higher relief. So let's go on to the next slide, which is to look at, I don't know how many of you have heard of the Stevenson Farmer Review. I think a very good piece of work in which really they're sketching out three tasks here. One is how to help staff to continue to thrive at work. The second is to identify staff who are struggling. And the third is what do we do about people who may be ill and possibly in work and possibly not in work. And I've kind of been thinking about this diagram a lot in the work that I've been doing in the last year or so. So a lot of what's being offered through the NHSE website, the Horizons material, is about helping staff to thrive under the pressure of these primary and secondary stressors in the pandemic. But there will be people who struggle. There are people who will be distressed by it, and we need to help them not to become ill, but to go back to thriving. And this is the current material that's being debated and discussed about how best to do that in the task force. And then we need to think about a much smaller number of people, hopefully, who are made ill by dint of the work they do. And that, again, takes me back to why the recovery phase is quite so important. If we go on to the next slide, which is a diagram, I hope you'll see that this is a line diagram showing of the kind of things that were coming out of the work that I've been doing for the Royal College of Surgeons about sustaining the workforce, responding to staff who are struggling, and providing services who certain staff maybe need more advanced care. Some of them might even require referral to a specialist mental illness service. I hope that number's very small. And I think the most important thing to stress there is the bit at the top left, which is about reintegrating people into work. We really need to get that right. Now, my view is that we need to be thinking about these things prospectively. That if we were to take the positive regard in which health service staff are receiving right now, and we took charge of the agenda in a more positive sense, we might be able to sort out some of the past maladies where I think, regrettably, in large measure, the NHS hasn't necessarily cared sufficiently effectively for its staff. And we might need to, well, I think we do need to improve that considerably, not in all organisations, but in a substantial number. And could we use what we learned from the pandemic to actually seed some of that work and propel it? It doesn't have to be my model. It could be whatever model seems most appropriate. But I'm very keen that we take this opportunity to grasp the agenda in an affirmative kind of way. So let me stop there. Adrian, thank you very much for this invitation to talk. I've been very pleased to air some of this. And if anybody wants to get back to me about what their thoughts are about how we might tackle some of these weighty matters, I'd be only too pleased to hear from them.
Well, thanks, Richard. Thanks for your expertise and all the work that you've done in this area. And we'll come back to you with some questions later on. We're now going to move on to Professor Sir Simon Wessely, known, I'm sure, to all of you Simon is currently the president of the Royal Society of Medicine, the past president of the Royal College of Psychiatrists. He's Regius Professor of Psychiatry and co-director of the King's Centre for Military Health Research and the Academic Department of Military Mental Health at the Institute of Psychiatry, Psychology and Neuroscience. He's an expert in both these areas. So, and Simon will actually be joining us by video. So I've got some questions myself. Simon wants to do this in form of a Q&A, but actually there's one question that's already been asked by our audience, and I'm going to put straight to Simon. And Simon, this is that there's an observation from World War I. Lord Moran, in his book, The Anatomy of Courage, described the phenomenon of battle fatigue and stated that no one has unlimited reserves for courage. The medical staff on the front line of COVID are in a similar situation. How long can we rely on their altruism? Are we putting in any systems to relieve them from this onerous duty to recover and recuperate? So over to you, Simon.
Thanks very much, Adrian. Can I say what a good job you're doing, actually? Since I left the college, it's improved massively. And I'm very pleased I never had to deal with anything approaching what Wendy and you had to deal with. I mean, it's interesting, isn't it? I noticed Richard made some allusions to war, and you just have now, and your question has as well. And it is very tempting. I mean, everyone says we're at war. The WHO do, Trump does, God help us. The Archbishop of Canterbury has, and the Queen in her speech did, and she made an allusion to "we'll meet again," which I think the whole population knew exactly what she was referring to. But I think that can be, those analogies can be taken a bit too far, actually. I don't think we are at a war. People say the virus is the enemy, but it kind of gives it a malevolence and a personality almost that we don't, which viruses, of course, don't have. I'm staring at a lovely picture of Richard Williams now. I'm not quite sure if that's intended or not, but very, very, very handsome you look there, Richard. So are we at war? Well, it's not the reason why I'm careful to avoid it, although we slip into it when we talk about frontline workers, etc., is the circumstances are very, very different, and there's a tremendous. We are taking lessons from the Blitz. You started out with Richie Calder's excellent book, but you have to remember that the thing was very different. That the first thing was that during the entire wartime, that no one had to endure deliberately, as a matter of policy, social distancing. Throughout the war, the pubs were open, the restaurants were open, the cinemas were open, the theatres were open, even though that led to loss of life, sometimes dreadful loss of life from direct hits on a cinema and a theatre during the Blitz, both of them costing several hundred lives. But it was felt more important that social solidarity and interaction and intimacy were to continue. And of course, this is what we're having now. It's, I think, unprecedented in our history, where we are deliberately creating social isolation, helped a little bit by social media. And it's ironic that, this time last year, we were all talking, and the college was talking about the malign effects of social media on the mental health of young people. And now we're all congratulating and thanking our lucky stars that social media exists because of the support it can give to young people. Probably a zero-sum game. But I think those analogies are a bit difficult. I also think that one of the reasons may be that we're seeing reasonably resilient healthcare workers at the moment. The support from the population, etc., is very strong, etc. But at least to them in their place of work, when I've been into work on a few occasions, I've been allowed in. The one thing they are getting is the ability to at least have conversations in real time with real people and not be staring at a screen as a picture of Richard, as I still am. And I think that does make a difference, and the experience of the rest of the population may not be quite like that. But the answer then, finally coming back to Lord Moran, who was Charles Wilson and Churchill's doctor. By the way, just to be slightly pedantic, because I am pedantic, he wrote that in 1945 when he wrote The Anatomy of Courage. But in 1918, at the end of the war, that was actually not the view he had at all. He actually believed that resilience in wartime was a question of character. And some people had it, the right stuff, as we would call it now, and some didn't. And if you didn't have character, you would eventually break down. But if you did, you could withstand the worst that the war could throw at you, maybe having brief lapses. But nevertheless, so long as you had character, but also good leadership, believed in your cause, and had been well trained, you wouldn't break down. So he changed his views completely into a rather more modern view, which is finally, if you push people too hard, even the best will crack. So that's the Lord Moran of his second half of career. But when he was a regimental medical officer in the First World War, he did not believe that at all. He believed it was fundamentally a question of character, a phrase that we don't use very much now, but to the Victorians and Edwardians who fought the First World War was a very essential part of courage. Another word we use less, and a word that we don't use at all would be the opposite of course, would be showing cowardice, a word that we just simply don't use in this context at all, but was extremely familiar to the Edwardians and the Victorians of the First World War. It was a concept they felt was very important, just as they felt that courage, its opposite, was very important. So we've moved on from them and from then, and I'm glad we have. But we mustn't read our own contemporary concerns into what the people of the First World War said. Adrian.
Okay, thanks, Simon. Just a couple of questions from me. This has been a time of great change, great innovation over a very short period of time. What are your initial thoughts on what we will and should keep, what we should let go, and what we should be cautious about?
That's exactly word for word. I'm doing an interview with Matt Hancock next week, and that's exactly word for word what I wanted to ask him. I don't know. I think obviously some of the things we will keep, the way that we managed to transform general practice. What we could have done in 10 years, we've done in 10 weeks. The number of people, it seems that a huge number of people don't really require the face-to-face meetings with GPs that we have been expecting, and that some of the new electronic systems, particularly which still have a person at the end of it, I don't mean the artificial intelligence systems, but the ones in which you can speed up the consultation, you can get a fast triage by a real doctor, but telling you whether or not you should go to a pharmacist, come to see them, go straight to casualty or whatever, are clearly reducing time and the need for people to travel. And I think that will be taken up as commonplace. As to what we won't keep, I have to admit, I hope that we won't keep Zoom and Skype and everything. I just detest them now. I can't bear staring at, well, Richard Williams has gone now, so now I'm seeing you. So maybe that's an improvement. But I hope that we will not think that everyone can just work from home. I think that also puts tremendous strain on families, and also remove some of the things that make jobs bearable and also possible. And it's remarkable how much the work of a hospital and university depends upon corridor conversations that become very difficult to achieve when now all we do is meet in groups. So I think we will not completely abandon that. Maybe we will abandon long haul flights to give a talk in Los Angeles and then come straight back, and that's fair enough. But I still think fundamentally we will exist in groups, and we will still find ways, for example, to go to the Royal College of Psychiatrists. Sadly, not this year, but next year. People don't just come there to get knowledge, they come there for a myriad of other things that will not be digitalized.
Okay, thanks for that. And in relation to the research questions arising from COVID, you've done a lot of work in this area, but this is a really unique situation. So what are your initial thoughts of the main research questions in relation to mental health?
Well, there was a paper published this morning in the Lancet Psychiatry, which is freely available, which is a kind of a mental health strategy for what do we need to know in the coming months. And I suppose it boils down into three really. One is what exactly does this virus do? If, as it's looking increasingly likely, it is neurotropic in its mechanisms, that throws up a whole series of questions in neuropsychiatry and psychiatry that we need to be prepared for and also monitoring for. What I'm hearing, and I'm not someone who does go on to ITU and ICU, but those who do say a remarkably high, even higher than normal rate of confusional states that you would not normally expect at this rate. We also know particular symptoms that people are mentioning, which clearly indicate neurotropism, anosmia, and I've forgotten what loss of taste is called now, but we'll just call it loss of taste. And of course, we need to remember the example of encephalitis lethargica. And we don't know what this particular agent does, but we've had agents before that seem to have long-term neuropsychiatric sequelae. So we need to be watching for that and monitoring that, and the studies need to be done, and also to see what we can do to, if that is the case, to block the virus entry to the brain. And we can also expect a rise in fatigue syndromes, one of my particular interests, for a myriad of reasons, including the virus itself, but including how we react and issues like that. And then the second thing are into unknown territory. What will be the consequences of prolonged isolation and social distancing? Other than saying that the work we did looking at previous episodes of quarantine, which were much shorter and didn't take place in this country, but did take place in others, but for shorter periods of time, suggests two things. One, that there will be psychological impact. We looked at 25 studies, 24 showed that there were. These will, now obviously these will affect those with, it's barely, it's not really research question because it's known. Those with pre-existing mental health disorders will be more affected, period. We also know that those who suffer economic hardship will be more affected. And to be fair to this government, it has picked that up and done, something we never would have thought possible only 2 months ago, but to spend 7.5% of the GDP that the Chancellor did within 7.5 days of becoming Chancellor is something that I think no one could possibly have ever imagined. And that's good, because that will reduce some of the consequences, but not all. And then the other consequences is how long will the solidarity that everyone has been talking about, and which is remarkable, what we've seen is the biggest single behavioural change in history, happened even before the government mandated it, the way in which the compliance with before it even became the regulations, as it were, people was already a dramatic drop in social interactions, travel, etc., which then accelerated. And something like 90 to 95% compliance has now been achieved. And that's, of course, created some surprises, because I don't think the government or anyone else expected that, just as they didn't expect that schools would go down to 2%, which has also cast some doubt as to the assumptions on how many of us will get infected. But then the question is, how long can we tolerate this? And I just simply don't know, but I don't think it is as long as some of the epidemiologists and modelers are assuming. And I think we will start to see cracks appearing, and that will have very profound consequences for the future, where some people are obeying the rules and some aren't, and some people are doing better than others. And again, looking back at the history of pandemics, you see great fractures appearing in prolonged pandemics, and you also see discrimination, stigma, and so on arising, which at the moment we're not seeing. But if the script goes off, we can expect that as well. And those, I think, with mental illness will once again suffer more than the rest of the population.
Okay. Well, thanks, Simon. I think we've got 10 minutes to go, and I'm going to broaden it now to some of the questions that have come in, and I'll ask each of you in turn to answer those questions. I'm going to roll 3 questions into one. I'll ask one of them specifically, and this will be for Clem. So we've got a question saying, I'm wondering if there's any specific guidance which refers to best practice when managing patients with SMI who lack capacity re their decision not to shield or socially distance, but are not acutely unwell and therefore do not require admission under the Mental Health Act. There are 2 other questions related to that. We've had a lot of inquiries about the public health legislation that's also part of the Coronavirus Act, and whether that's come into force. Has anybody actually used it? And again, what is the legal position regarding a patient with SMI who is COVID positive and is refusing to take the necessary precautions? So Clem, if you could, it's a complex question, but if you could, if possible, give a brief answer. Over to you.
Thank you very much, Adrian. So I'm not aware of any specific guidance in relation to this, but I think that's something probably as a college we can double check and look at. I think the issues are, how capable do you need to be to know that you're making a bad decision? Is this really somebody who lacks capacity, or somebody who is choosing to make an unwise decision. If somebody is not detainable under the Mental Health Act, then obviously you can't use mental health legislation if they don't satisfy the criteria for detention under the Mental Health Act, such as, mental disorder of a nature or degree, which warrants admission to hospital. I suppose the bottom line is that if there's a severe threat to the public, then the public health legislation may come into effect. Sorry, can you just, what was the second part of the question, Adrian, the second bit? Because I know the third bit again was around the public health legislation. I haven't actually had the opportunity or need to use it because I'm working in an inpatient service where all my patients are sectioned under the Mental Health Act. We do have issues, but generally the behaviour related to those issues is related to the mental disorder and behavioural problems related to the mental health disorder. So we are using, we are treating them as we would normally in terms of their behaviours. I have seen on social media that other psychiatrists in liaison settings have actually advised that the public health legislation be used, where you've got people who are displaying, refusing to agree to the necessary precautions, but I haven't had personal experience of that. Thank you.
Okay, thanks for that. Well, we'll look at these questions, and if there's more detail that we can give to some of the answers, we will go away and actually look at them and actually publish the answers to these questions as well. I want to move on to another question about looking after the workforce. And Richard, this question really for you. Is it more important to improve the pay and working environment for NHS staff rather than increase care? Richard.
Well, I don't know if I entirely see the distinction, but I think the really important thing is to recognise what I've said about the secondary stressors. Some of those are about how we care for staff, but a lot of them are about the conditions in which they do their work. There is no doubt from my talking to junior doctors, senior junior doctors, who are a year away from being consultants, that they find the lack of privacy, the lack of spaces where they can go, the dreadful things that they report about their employers doing about not letting them have coffee and things of this sort, and the absence of rooms where people who've done a 12-hour shift can go and sleep before they are safe to drive home, are the things that bother them most. They probably bother them more than they are bothered about the pay, though pay comes in terms of a sort of a mark of people's standing. I think pay is one of those talismans that actually tells you something about the esteem in which you're held. So I think that's probably much more important to get the secondary stressors right before you think about any kind of therapeutic things. I think it's those working conditions that I think stand out for me. And I always say to people, before you want to make a diagnosis of somebody who's showing signs of distress, let's look out for the secondary stressors. If we could reduce those, then it seems to me that there is a good chance that the person won't need any further, more formal intervention in the form of assessment or treatment. Does that answer the question, Adrian?
Yes, it does. Thank you very much, Richard. We've got two more questions that I'm going to ask first to Clem and then back to Simon. Clem, there's been a lot of questions about remote working, video assessments in relation to the Mental Health Act. What are the rules about this? What's the legal side of it? And what's your advice about remote assessments?
Yeah, thank you very much for those. So we are working in unprecedented times, and I have to say, personally, when I first heard of these changes to the Mental Health Act, no SOADs, one doctor being able to section somebody, I thought I was, stepping into the pages of a dystopian drama. And but you know, the world has changed in the last 3 weeks. We are using different ways of communication. We are using telephone communication and video conferencing, and the method of assessment is not laid down within the Act. Usually such methods are laid down, for example, if necessary, in the Code of Practice. So we haven't really had to address this issue before. But I think there was a question on CTOs, whether you could renew that remotely over telephone. And I suppose the answer would be, do you feel that you're able to do an adequate assessment of somebody over the telephone or over a video conference? Are they in agreement with the CTO continuing? You know, have you got all the other information? And I think if the bottom line is, if you aren't able to see that patient to renew the CTO, the patient is likely to deteriorate without the CTO, but you are able to assess them via the telephone or video, and that will keep that patient well and reduce their risk of harm, then I think that would be quite justifiable, as long as you document everything that you do. The other question that's come up is the idea of video assessments for Mental Health Act assessments. Again, you know, this is a brave new world. I personally, I think, would find it very, very difficult to assess somebody on a video. And I think the whole point of the legislative changes, if they should come into force, is that their recognition that if there are less doctors available, then you would only need one doctor to do the assessment. But I think personally that would be pretty tricky to do, you know, to take away somebody's liberty without a face-to-face assessment. The third thing I just want to say on my Mental Health Act and rights of patients horse is that for us, we're all struggling with the idea of just going out once a day or not going out at all. And I think we should all remember that for our patients detained under the Mental Health Act, this is their life. They are at the mercy of their RC, you know, myself included, whether or not they get their half-hour leave to go out and have a cigarette. So maybe this is a time for us all to remember and to remind ourselves that even if things are done in our best interests, we may not always like them, and to remember our patients next time we give or withhold leave.
Okay, that's a very important point to make, Clem, so thanks for making it. Just finally, very briefly, in the last 30 seconds, for Simon, a query about how can we find out more about moral injury and the trauma that some staff will experience. Will it lead to higher rates of PTSD?
Well, the second one is the evidence suggests it will, but the rates vary dramatically from epidemic to epidemic on the circumstances, but I've not seen any that suggest a lower rate. On the first one, on moral injury, I have to say I still think the best reference is the thing that Greenberg and I wrote in the BMJ about 3 weeks ago, and that's freely available, not behind any paywall. So just look up Greenberg and Wesley BMJ, and that I think that's a good starting point. It's a good starting point. But I would say that, wouldn't I?
Well, thanks for that, Simon. So thanks to all our speakers, to Clem, Richard and Simon. Thank you for all you're doing and for tuning in. Keep the questions coming. We'll keep the answers coming as well. This is new territory really for all of us. And I just wanted to say a big thank you to the team at the Royal College. If you're wondering what the college is actually doing, the college is still very active, very much operational. The building is closed, but we've got staff working remotely in a very effective way. So in particular, big thanks to Isabel and to Katie, our producers for the webinars. So enjoy the rest of your evening if you can, and thank you for all you'll do in the next few weeks. Thank you for joining us.